Hello everyone, my name is Natalie Armstrong. I'm from the University of Leicester and I'm going to be talking to you about our work studying the implementation of the patient activation measure, and the people that I completed this work with are listed on the slide. So many health systems display an increasingly strong policy emphasis on finding ways to encourage people to be more involved in their health and healthcare, and it was against this backdrop that we were commissioned jointly by the Health Foundation and NHS England to complete a qualitative evaluation of early activity around patient activation and its measurement. So patient activation refers to an individual's knowledge, skills and confidence in managing their health and healthcare. It's measured by something called the Patient Activation Measure, or PAM, which is a commercially licensed tool originating in the US. The PAM contains a series of statements associated with patient activation, and these relate to knowledge, there's an example here, beliefs, another example, confidence in interacting with healthcare professionals, and self-efficacy. And patients rate the degree to which they agree or disagree with each of these statements. The result is a score which places patients at either low activation or high activation, or somewhere in between. So why the interest in PAM? So while not always of the highest quality, there was some evidence which suggested that activation levels could be potentially important, and I've listed some of the main points to come from that here, and you can see some of the outcomes that look like they might be associated with activation. So things that we would perhaps want to see, so better clinical outcomes, lower hospitalisation, lower use of emergency services, and so on. And there was a lot of interest in the UK in the PAM, which had been used extensively in the US and elsewhere, and was starting to gain some traction here. And the publication of this report from the King's Fund in 2014 was a publication which started to draw some of that together. So keen to explore this potential, NHS England established a learning set comprising 5 clinical commissioning groups and 1 disease registry, gave them licences to pilot the PAM however they chose. Piloting and learning was important because although the PAM had been used elsewhere, little was known about how it could be implemented and used in the UK. And to capture the learning across these pilot sites, we were commissioned to undertake a qualitative process evaluation of the implementation. So we had one work package, which was a kind of high-level work package with each of the organisations. So a focus on core teams over the project duration, which was two and a bit years, thinking about what are they doing with the PAM, how are they doing it, why are they doing it like that, and how are they getting on. And a second work package which looked at 6 purposively sampled projects within the sites, looking at understanding and use of the PAM and the wider concept of patient activation in practice with healthcare professionals and with patients. Data collection and analysis. So we completed 123 hours of observation at learning set events and at project-specific events, 112 interviews with core staff, frontline staff and patients. We looked at lots of documents like project plans and reports and training material. A constant comparative approach to analysis was used, and we have published a range of reports. So this is a very busy table, and you don't need to take in all of the detail, but this is just to convey the message that across the 6 sites, which are listed down the left-hand side, there was an awful lot of PAM-related activity going on, or to put it another way, the PAM was being used in lots of different kinds of activities and interventions. So lots of different kinds of projects and services, very variable scale to these, from several thousands of people across a CCG population to very small numbers for a specific intervention. Lots of variety in terms of the conditions and patient populations, the function that the PAM was serving, I will come back to in the slides later on, and a variety of providers being involved in these activities. So, drawing on our ethnographic study, what I want to do in this presentation is to look at the work that projects and those within the organisations were doing to craft problems that the PAM was then a meaningful solution to. So the PAM was seen as a natural fit with sites' aims to respond to the outcomes and care that they were being encouraged to deliver. Sites were already engaging with the broader changes to care outlined in things like the NHS Outcomes Framework and the 5-year forward view. For example, taking a holistic view of patients, keeping people out of acute care wherever possible, making care more community focused and integrating commissioning. And sites were convinced of the potential gains to be made by helping people to manage their own health using person and community-centred approaches, even though sometimes the results from their previous initiatives had been mixed. They'd become increasingly aware that different people needed different kinds of support with self-management. The PAM, they thought, offered the opportunity to understand which patients needed what level and type of support, and so fitted a gap in the toolkit, if you like, for enacting change at both the strategic and frontline level. As this tool, the PAM, was being made available to them by NHS England, it was seen to have high-level endorsement, and because it wasn't disease-specific, it could be used with different patient groups and in both social and public health initiatives. So there's an example here from a core team member at one of the sites, making the point that the PAM can speak to lots of different audiences and generate the kinds of data that are meaningful to different audiences. So outcomes that matter to clinicians, outcomes that matter to patients, outcomes that matter to finance managers. You can tell a story that brings everybody together around the PAM. So there was a lot of excitement about this tool and the multifaceted things that it offered. It was clear that many people felt some frustration at being encouraged to focus on what were often regarded as relatively soft, process-oriented changes, things like changes in relationships between practitioners and patients, or the ways that individuals lived with their condition, changes in individuals' attitudes and beliefs towards medicine, for example. They felt that there was no obvious way through which these changes could be measured, and they were worried that without measurement of some kind, there was a danger that initiatives and projects that they were putting in place could be questioned, or the value of them could be questioned, and their progress would stall. So they saw the PAM as offering a welcome solution to what they saw as a problem of measurement. So there's an example here from a member at one of the sites talking about actually, as a CCG, if you want to create change in what you're doing, you need evidence to write a business case. You've got to have something with some certainty that says, okay, this thing is making a difference, here are the outcomes, and you can use that to write your business case. So for all of the sites, the PAM was seen as a tool that could augment their ongoing efforts to embed person-centred approaches to care, and thus many saw the PAM's potential as a measure that could be used to bolster their existing approaches rather than as an additional standalone element of their interventions. So two clear logics of potential use were therefore apparent: measurement and tailoring. Under a measurement logic, before and after PAM scores, as I've suggested, sites thought could be recorded for patients taking part in interventions like health coaching or structured education programmes that they were commissioning. And the logic of measurement was that the tool would deliver a robust metric able to inform commissioning decisions. Using the tool to tailor care also held much appeal. Strategic level staff were positive about PAM scores as a means to tailor care. And this could be as a means of identifying the most appropriate intervention for any patient, so tailoring selection of interventions, or within an interventional care episode to adjust delivery, so tailoring the enactment or implementation of an intervention. And over time, many sites began to think about maximising the benefit from any PAM-generated data, and two approaches to this emerged. The first was seeking to use the same data, as I've suggested, for different purposes. And the second was aggregating PAM scores collected in sometimes quite different projects and contexts and trying to put them together into a population-wide data set. And few problems with doing any of these things were anticipated, but in a separate paper which I've referenced on the slide, we showed how administering the PAM in practice was often not as straightforward as expected. Professionals reported that they were aware of and understood the guidance about administration, which was that ideally patients completed it on their own with no involvement of anybody else, and that there was very strict wording of the statements that should be adhered to. But they struggled to comply in practice. In all the sites, we found evidence of some form of what we called mediated completion, by which we meant that the PAM was completed with significant input or assistance from others, frequently going beyond the quite limited deviation which was permitted by the developers. So towards the end of our time with the teams, we asked them to reflect on their experiences so far and what they had learned. In terms of what they could have done differently, many responses centred on the need to contextualise the PAM within the broader shift to person-centred care and the importance of ensuring that this was happening early in the pathway. So the first data extract here talks about, in hindsight, would have preferred to get patient activation in at the ground level in primary care, perhaps get a patient activation score for every patient across the CCG, perhaps get that kind of built in as part of an annual process, and then you're working with the patients thinking about where they are and what we can do with their level of activation, rather than perhaps rushing to specific projects and loading it into those. And the second extract is quite interesting. So in this case, the person says, what we have achieved is that everybody now knows what a PAM is and they will have an opinion about it. And awareness raising, for better or worse, was something that most, if not all, felt they had achieved. And it was interesting, certainly in our purposefully selected frontline projects, sometimes very strongly held views by both healthcare professionals and patients about the PAM and what it was measuring and the relative value it was offering. So the apparent desire to use the PAM widely and in sometimes quite diverse ways could challenge the organisation's ability to clearly articulate the problem they were seeking to use the PAM to solve. The desire for hard data on a construct like patient activation was clear, but the rationale behind this and the purposes for which such data could then credibly be used was sometimes more opaque. Local policymakers' constructions of these problems could be challenged by healthcare professionals asked to use the PAM in practice. So the PAM as a tool was championed at a national level, and healthcare organisations encouraged and supported to engage with it and put it to use locally. But as we saw in our work, the work that the organisations had to do as they sought to identify and craft problems at the local level to which the PAM and the data it generated could credibly be seen as an appropriate solution was sometimes significant. The most fundamental issue, and one which underpins most of our findings, was the need for clarity and shared understanding of why the tool was being used and what function it was serving. So knowing what the underlying logic of use was. And it was vital that, besides being clear at the strategic level, this understanding be shared by staff and patients at the front line, which wasn't always the case. As many people's perception of the PAM, and I haven't shown you any data of this, but you'll have to take my word for it, many people's perception of the PAM at the front line was as just another burden of data collection. So clarity of purpose being critical, because many of the decisions about how the PAM can best be integrated into services, how it could be completed by patients, and how the resulting data could be shared and used kept coming back to this key point. So the final slide, I will thank the funders of the evaluation, I will thank the organisations that we worked with. The final report can be accessed via that link. If that doesn't work, let me know and I will email it to you. And thank you for listening.